Assalamu alaikum dear students. Today our topic is deep cervical fascia of the neck. We will enumerate the layers of the various layers of the deep cervical fascia. Then we will study the diagram of the cross section of the neck, and we will study the various layers of the deep cervical fascia in it. Then we will describe every layer of the deep cervical fascia and the clinical importance of the deep cervical fascia. The deep cervical fascia is very important because it forms capsules for the glands, and it forms protective covering around the muscles, and it forms also protective covering around the neurovascular bundles. It forms various sheaths and tunnels, and there are spaces between them, and these form facial planes through which infection or pus may spread. From outside inward, the names of the fascia is there are three layers of the deep cervical fascia. The black one on the outside is the investing layer of the deep cervical fascia. Next to it, this is the pretracheal layer of the deep cervical fascia. So it is pretracheal fascia. The pretracheal fascia contains the esophagus, the trachea, the thyroid gland. Since it is in front of the trachea, so it is called pretracheal, although it is all around. So it is also called visceral compartment because it contains these viscera. It also contains these muscles, infrahyoid muscles. So the pretracheal fascia form a compartment which is called visceral compartment, and then in front of the vertebra, this layer is called prevertebral layer of the deep cervical fascia, and it forms a compartment which is called the vertebral compartment. So these are the three layers: the investing layer of the deep cervical fascia, the pretracheal fascia, the prevertebral fascia, and these three contribute to form a sheath around these three structures which is called the carotid sheath. This pretracheal, the investing layer, and the prevertebral contribute to formation of a sheath around these three structures which is called the carotid sheath. These structures are, this may be either common carotid artery or internal carotid artery. This is internal jugular vein, and on the posterior side this one is the vagus nerve. So this compartment is neurovascular compartment. So the deep fascia of the neck divides the neck into various compartments so that the various tunnels and sheaths formed by the fascia help them to move easily. Now we will discuss each and every layer of the deep cervical fascia, from investing, pretracheal, and the prevertebral. These are also shown here. The outside, this one is the investing, this is investing from all sides, and these are the various sheaths formed by the fascia. So the front one, this is the pretracheal layer forming a sheath, a compartment called visceral compartment, and this is the prevertebral fascia forming a compartment called vertebral compartment, and on either side there is carotid sheath. So these two are carotid sheaths, this one and this one. Next we will start with investing layer of the deep cervical fascia. Now we will discuss the attachment of the investing layer of the deep cervical fascia. Posteriorly it is attached to the external occipital protuberance, then to the superior nuchal line, then to the mastoid process, then to the angle of the mandible, then to the lower border of the mandible up to the symphysis mentari, where it becomes continuous with its counterpart on the other side. Inferiorly, it is attached to the spine of the scapula, the acromion process of the scapula, and then on the upper surface of the clavicle up to the jugular notch of manubrium sterni. It is attached to the jugular notch of the manubrium sterni. So that was the superior and inferior attachment. Now posteriorly it is attached to the ligamentum nuchae. Ligamentum nuchae is attached above to the external occipital protuberance and below to the 7 cervical vertebra. So it is attached to the ligamentum nuchae posteriorly in the midline, and from there goes to the spine of the scapula. Anteriorly in the midline it is attached to the symphysis mentari, then the hyoid bone, and then the jugular notch of the manubrium sterni. So that was the superior, inferior, anterior and posterior attachment of the investing layer of the deep cervical fascia. Now we will trace the investing of layer of the deep cervical fascia vertically. When we trace it upward, just above the hyoid bone, it splits into two, and these two layers enclose the submandibular salivary gland. The interior layer covers the surface of the submandibular gland and is attached to the lower border of the body of the mandible. The posterior surface covers the medial surface of the submandibular gland and is attached to the mylohyoid line. Posterior to the submandibular gland here, at the lower pole of the, here is the parotid gland. At the lower pole of the parotid gland, it again splits into two layers and encloses the parotid gland. The anterior layer is strong and goes over the surface of the parotid gland and is attached to the lower border of the zygomatic arch. The posterior layer goes behind the parotid gland and get attached to the external acoustic meatus and the styloid process. The part of the fascia between the styloid process and the angle of the mandible is thickened, and it is called the stylomandibular ligament. This stylomandibular ligament separates the submandibular gland from the parotid gland. When we trace downward, it split to enclose two spaces, one above the suprasternal notch and the other above the middle third of the clavicle. We will discuss these later on. This is the investing layer of the deep cervical fascia. It splits to enclose the parotid gland. This is, we want to show you how the parotid gland is enclosed. So the investing layer of the deep cervical fascia splits to enclose the parotid gland. The anterior layer passes over the parotid gland superficial layer and gets attached to the zygomatic arch, lower border of the zygomatic arch. This layer, the anterior layer that passes above the parotid gland, is called the parotido-mesenteric fascia. The other layer that goes deep to the parotid gland is attached to the external acoustic meatus and styloid process and form the stylomandibular ligament between. This is the how to show you that how the submandibular gland is enclosed in the fascia. This is the body of the mandible, this is the tooth, and this is the hyoid bone. When we trace the investing layer of the deep cervical fascia above the hyoid bone, it splits into two. The superficial layer, which get attached to the lower border of the body of the mandible, and the deep layer which gets attached to the mylohyoid line. Now we will study the inferior tracing, where it forms two spaces, one over the suprasternal notch and other over the middle third of the clavicle. We see then that the investing layer of the deep cervical fascia, when we trace it downward, it split to enclose the suprasternal space at the suprasternal notch of the manubrium. That it splits to enclose the suprasternal space. Forms two layers, one goes posteriorly and one anteriorly and gets attached to the suprasternal notch. This suprasternal space is also called the space of Burns. It contains the head of the two sternocleidomastoid muscles, the interclavicular ligament, the jugular venous arch, and some lymph nodes. These are the contents of the suprasternal space. The middle third of the clavicle, above this, the fascia also splits into two layers. One layer gets attached to the anterior aspect of the clavicle, and another the posterior layer gets attached to the posterior aspect of the middle third of the clavicle, and between these two layers a space is enclosed, and that is called the supraclavicular space. The posterior layer, before attaching to the posterior aspect of the clavicle, it encloses the inferior belly of the omohyoid muscle. This is the inferior belly of omohyoid. So it encloses the inferior belly of omohyoid muscle and then attaches to the posterior aspect of the middle third of the clavicle. The contents of the supraclavicular space are the terminal part of the external jugular vein and the supraclavicular nerves before they become cutaneous. This is the supraclavicular space. This is the clavicle, this is the subclavius muscle and the clavipectoral fascia, and this is the investing layer of the deep cervical fascia. This is the anterior layer attaching to the clavicle, and this is the posterior layer enclosing the inferior belly of digastric and then attaching to the clavicle. And this is the external jugular vein, and this is the supraclavicular nerve. So this is the supraclavicular space. The investing layer of the deep cervical fascia also form pulleys, fascial pulleys to anchor the tendons of digastric muscle and omohyoid muscles. They form pulleys for the tendons of digastric muscle and omohyoid muscles. We have seen the vertical tracing. Now when traced horizontally, this black one is the investing layer of the deep cervical fascia. When we trace it horizontally from posterior side, it first splits to enclose the trapezius muscle. This is trapezius muscle. Then again it unites and form the roof of posterior triangle. This is the posterior triangle. Here is the location of posterior triangle. Then again it splits to enclose the sternocleidomastoid muscle and then unite to form the roof of the anterior triangle, and then continues. So when traced horizontally, it encloses two muscles, the trapezius and sternocleidomastoid, and form roof of two triangles, the posterior triangle and the anterior triangle of the neck. And it form, we have said already, that it form pulleys to anchor the tendons of digastric and omohyoid muscles. To remember these things, there is a rule of two. The investing layer of the deep cervical fascia presents everything in twos, encloses two muscles, trapezius and sternocleidomastoid, form roof of two triangles, anterior triangle and posterior triangle, splits to enclose two glands, submandibular gland and parotid gland, splits to enclose two spaces, suprasternal space and supraclavicular space, and form two fascial slings or pulleys for the inferior belly of homohyoid one, and another is for the intermediate tendon of digastric muscle. So this is, to remember this, there is a rule of 2. Now coming to the pretracheal fascia, when we trace the pretracheal fascia in a vertical direction, above it is attached to the hyoid bone, then to the oblique line of the thyroid cartilage, then it splits to enclose the thyroid gland. It splits to enclose the thyroid gland and form its capsule, the false capsule of the thyroid gland. And it is attached to the cricoid, arch of the cricoid, by a fibrous band called ligament of Berry. This ligament of Berry connects the lateral lobe of the thyroid to the cricoid cartilage. Below the thyroid gland, it unites again, enters the thorax, and is continuous with the fibrous pericardium. So this is the vertical tracing. On horizontal tracing, what happens that it merges with the carotid sheath. It leads to the formation of carotid sheath. This pretracheal fascia, the investing fascia, and the prevertebral fascia, they all contribute to the formation of carotid sheath. So the attachment of the pretracheal fascia to the hyoid bone and the thyroid cartilage and the cricoid cartilage allow the thyroid gland to move up and down during swallowing. The layer of the prevertebral fascia, which covers the posterior aspect of the surface of the thyroid lobe, is ill-defined. As a result, when thyroid gland enlarges, which is called goiter, it bulges posteriorly and compresses the esophagus and trachea. It bulges posteriorly and compresses the esophagus and trachea and esophagus. The posterior layer is ill-defined, not strong. So it cannot bulge anteriorly, but it bulges posteriorly more and compresses these two structures when the lobe of the thyroid gland enlarges, as in goiter. Now we will trace the prevertebral layer. The prevertebral layer merges with the carotid sheath and it contributes to the formation of the carotid sheath. The prevertebral, the pretracheal, and the investing layer, both the three contributing to the formation of the carotid sheath. When traced laterally, it covers the scalene muscle, the levator scapulae, and the splenus capitis, and thus form the floor of the posterior triangle, floor or carpet of the posterior triangle, and the investing layer is forming the roof of the posterior triangle of the neck. So this is the investing layer forming the roof of the posterior triangle of the neck, and the prevertebral layer is forming the floor of the posterior triangle of the neck. When traced upward, it is attached to the base of the skull. Obviously, since it is around the vertebral column, so it will be attached to the base of the skull. And below, it is attached to the anterior longitudinal. It enters the superior mediastinum and is attached to the anterior longitudinal ligament of the upper 3 thoracic vertebrae. The anterior longitudinal ligament of the upper 3 thoracic vertebrae, it is attached. So above to the base of the skull and below in the superior mediastinum to the anterior longitudinal ligament of the upper 3 thoracic vertebrae. So that was about the prevertebral layer of the deep cervical fascia. Now we will talk about spaces in the neck. This is the pretracheal layer, anterior lateral part, and the posterior part. The posterior part, in front of the posterior part of the pretracheal layer of the cervical fascia, there is present esophagus and pharynx. So it is also named as buccopharyngeal fascia due to the presence of esophagus and pharynx. There is a potential space between the buccopharyngeal fascia and the pretracheal fascia. This is a potential space which is called retropharyngeal space. This space allows the expansion of pharynx during swallowing. It is continuous with the parapharyngeal spaces on either side. This is continuous with parapharyngeal spaces on either side of the pharynx. It is divided into two lateral compartments, this one and this one, by a midline fibrous raphe. Each lateral space contains retropharyngeal lymph nodes. They contain retropharyngeal lymph nodes. And abscess may form due to infection in these lymph nodes. And when abscess form in the retropharyngeal space, there will be a paramedian bulge in the posterior pharyngeal wall. There will be a paramedian bulge, not median, because in the midline they are joined together. So they cannot cross the midline, cannot come to the midline. So the pus will form a paramedian swelling in the posterior part of the posterior pharyngeal wall. In the posterior pharyngeal wall, they will form a paramedian unilateral bulge. Either will be on this side or on this side, but will be paramedian. There is another space which is behind the prevertebral fascia and in front of the vertebral bodies. This is called the prevertebral space. This is also a potential space, and this potential space, when tuberculosis of the cervical vertebra produces an abscess, then in this produce abscess in this prevertebral space, then what will happen? A median bulge will be formed in the posterior pharyngeal wall. Not a paramedian, but a median bulge will be formed in the posterior pharyngeal wall. So another space, they say that the prevertebral fascia divides into an anterior layer which is called the alar fascia, and the posterior part is called the prevertebral fascia. So there is a potential space between the alar fascia and the prevertebral layer. So this potential space is called danger space, and it's also communicate with the mediastinum, and the retropharyngeal space also communicate with the mediastinum. So they can take infection to the mediastinum. So that was all about the spaces in the neck. Investing layer, the pretracheal layer and prevertebral layer. This tubular condensation occurs around the common carotid arteries, internal carotid arteries, internal jugular vein, and vagus nerve. The vagus nerve lies posteriorly between the artery and vein. The carotid sheath is wedged between the three layers of the deep cervical fascia. The sheath is thick around the common carotid artery and internal carotid artery, and is thin over the internal jugular vein in order to allow its expansion during increased venous return. When the venous return is increased, the internal jugular vein can expand. That is why the carotid sheet above the anterior internal jugular vein is not thick. The carotid sheet extends above from the base of the skull below to the arch of the aorta. At the base of the skull, it is attached to the margins of the carotid canal and jugular fossa. And below at the arch of the aorta, it blends with its adventitia. If we take the cross section, we can see the relations. This is the ansa cervicalis, which we will be studying in the cervical plexus. So ansa cervicalis is embedded in the anterior wall of the sheath. The sympathetic chain, this is the sympathetic chain, is closely related to the posterior wall of the sheath and is plastered to the prevertebral fascia. So that was about the carotid sheath.